Hello, everyone, and warm welcome to today's edition of Patcast. Today is September 16th, 2025, and I'm Rifat Manan in California. So we are continuing with our Dermatopathology lecture series, and today's lecture will be the 12th one in that series. And we are very delighted and honored to invite as a speaker for today's session, Professor Philip LeBoit, who needs no introduction to our colleagues in dermatopathology. Uh, Professor LeBoit is very renowned dermatopathologist, and currently he is at the University of California, San Francisco, where he is professor of pathology and dermatopathology and dermatology, of course, sorry. And he's also the division chief there for dermatopathology and oral pathology at UCSF. So today he's going to talk on melanoma from clinical presentation to molecular diagnosis. And I want to take this opportunity to thank our colleague, Dr. David Casarino and Dr. Hadas Kapsky for helping us organizing this dermatopathology lecture series. Thank you so much, both of you. So over to you, Dr. LeBoit.
Well, thank you very much, Rifat, and thank you very much, David, for the kind invitation to speak this morning. My goal of the morning is to go through the spectrum of the most common forms of melanoma, not the exotic ones, look at how they present clinically, how they present pathologically, and say a little bit about the molecular changes behind them, because those are becoming more and more important in daily practice. And I'm going to make the assumption that many in the audience are general pathologists with an interest in dermatopathology, as well as dermatopathologists. And for those of you who started in the field some years ago, the basic principles of diagnosis of melanoma haven't changed, but the background music has. There's been a remarkable revolution in our understanding of the molecular basis of melanoma, and I'll outline some of that. So we'll look at melanoma from clinical presentation to molecular diagnosis. But first, a few general ideas about why the diagnosis of melanoma is so important. And I'm going to start with an analogy from almost now a half century ago. During the Cold War, the KGB used the Bulgarian Secret Service to carry out operations that they didn't want their fingerprints on, so that they had a little bit of distance from them. And amongst them was an assassination of a dissident, Georgy Markov. Georgy Markov's pictured on the left. An umbrella of the type that may have killed him is pictured in the center, and Waterloo Bridge in London is pictured on the right. According to the most prevalent theory, a Bulgarian agent had ricin, which is the most lethal toxin, gram for gram, that's known to science, or at least known to science at that time, put into the tip of an umbrella with a sort of cartridge that could shoot it into the skin of a victim, and walked behind Georgy Markov, touched the umbrella to his leg. Markov died hours later of ricin poisoning, the most lethal toxin known to man. Melanoma is probably the most lethal neoplasm known to science. Gram for gram, cell for cell, it has a lethality that few other neoplasms approach. If you look at colon cancer, breast cancer, and lung cancer, neoplasms often need to grow to several centimeters in size before they can kill. This is a lesion that's at most 4 millimeters across, has a domed surface, and a population of atypical melanocytes. If this was a breast cancer or a lung cancer of the same size, it probably couldn't kill anybody, or the chances of it killing someone would be minuscule. This particular lesion killed at least 4 people. It was in a young woman who had a biopsy of what was thought to be a changing mole. It was interpreted at the time at a very good referral center as an atypical spitzoid melanocytic proliferation. She died suddenly while taking a shower. Her husband was asked if there was a history of cancer. She said no, and her organs were transplanted into about a dozen patients, 4 of whom died of metastatic melanoma. I came across this lesion when I was a defense witness for the American Red Cross Society in a wrongful death suit in Sacramento, California. And to my knowledge, this is probably the most lethal melanoma of its size ever discovered. So why is melanoma different? As we've seen by the number of cells, it's the most malignant of tumors. So if you make a mistake on a small lesion, you can end up causing a lot of harm. It disproportionately affects economically successful people in their productive years. The most common occupation for a patient with melanoma is lawyer. Second most common is doctor. Some people think this is due to the Club Med effect. People without much of a tan go to the tropics where they're exposed to UV radiation with no protection and get mutations in their melanocytes. Until recently, metastatic melanoma was almost uniformly fatal. With the advent of checkpoint inhibitor blockade treatment, it's more and more treatable, but unfortunately, most of the time that there's widespread metastatic disease, it's a lethal neoplasm. It probably has more mimics than any other neoplasm, and as a result, for pathologists and dermatopathologists, there's a lot of anxiety, there's a lot of litigation, and there's a lot of grief that comes with it. Historically, there's been 2 different ways to view melanoma. One comes from the late Dr. Wallace Clark, and here his student David Elder on the right, and the other comes from the late Dr. A. Bernard Ackerman on the left. Dr. Ackerman held that melanoma was one disease, melanoma in situ was its intraepidermal stage, that melanoma seldom evolved from dysplastic nevi, was a single process, and that pathologists should just make diagnoses and not prognoses, and he even hated to give thickness measurements for melanoma. Dr. Clark thought that melanoma had several types, that melanoma in situ was an oxymoron and a term that really didn't belong in medical practice, that it often involved from dysplastic nevi, that it had different phases of growth that were linked to prognosis, and thought that pathologists should make both diagnoses and prognoses. A half century later, it turns out that Dr. Clark was right more than Dr. Ackerman was right. There were things that either one of them were right and wrong about, but on balance, the work that Clark did on the biologic forms of melanoma, the histogenetic types that he outlined, lentigo maligna, nodular, acral, lentiginous, and superficial spreading, correspond and track better with our current molecularly based understanding of disease than Dr. Ackerman's idea that melanoma was a single disease. Advanced melanoma is changing, and the treatments are changing, and they depend to some extent on classification. Modern treatment incorporates both individualized therapy, looking at the mutations that are present and seeing if there's activation of the MAP kinase pathway, and immune modulation, which is a one-size-fits-all approach. And both are used in modern treatment. Right now, there's a dominance for immune modulation. And to some extent, immune modulation depends on mutational burden. And Clark's distinction between lentigo malignant melanoma, which in the current WHO classification corresponds basically to high chronic sun damage melanoma, that form of melanoma has a higher mutational burden and is more likely to respond to checkpoint inhibitor blockade treatment than melanoma with a low mutational burden, as one can see in only intermittently sun-damaged skin. So those are the two common forms of melanoma: low chronically sun-damaged melanoma and high chronically sun-damaged melanoma. Outside of the European world, acral melanoma is the most commonly encountered form of melanoma, or it makes up at least half of melanomas, and is genomically distinct from the other forms. And then there are rare forms of melanoma, which we'll review this morning: mucosal, blue nevic, Spitz, desmoplastic, and very briefly, de novo nodal melanoma. So the first, and in the United States, one of the most prevalent types is melanoma in intermittently sun-exposed skin, or low chronic sun damage melanoma. It's probably the most common form of melanoma in Caucasians. The ABCDE rules, which we'll go over, which every dermatologist is taught in practically their first week of residency, are good clinical heuristics for making the clinical diagnosis. It can arise de novo or in pre-existent nevi. And oddly enough, the question of how often do melanomas arise in nevi remains as unsettled as it was a half century ago. The lowest percentage that's been given is in a paper by the late Dr. Clark, 4.5%. The highest is a paper from one of my former colleagues, Dr. Richard Segabiel, a student of Dr. Clark's, 45%. That's all over the place. That tells us that we really know nothing about how often melanomas arise in pre-existent nevi. Why? Because advanced melanomas overrun nevi, and it may be hard to find their remnants. And two, when melanomas arise in nevi, our tools to determine what is a true nevus and what are just small melanoma cells arranged in a pattern that looks like a nevus aren't all that great. Melanoma in intermittently sun-exposed skin usually begins at the dermal-epidermal junction, and it starts as a flat pigmented lesion. When flat pigmented lesions are small, they're called macules. When they're large, they're called patches. And the term melanoma in situ, although Dr. Clark hated it, is pretty well accepted now in dermatologic and pathologic practice. I mentioned the ABCDE rules. E is in there also. It used to just be ABCD. Asymmetry, border regularity, color regularity, diameter, and evolution. And those are features that are clinically evident in a lot of melanomas and intermittently sun-damaged skin. And you can see that diameter, this is a large lesion, it's asymmetrical, it has color changes throughout the lesion. And if one could take a journey back in time, it would have started as a small brown macule and evolved to get to that size. That didn't happen overnight. In melanomas in intermittently sun-exposed skin, many of them don't have a flat component and are just nodules. So nodular melanoma is said to have no radial growth phase, but there probably is a short one that has just been overrun by the rapid evolution of a dermal component that's expanded. The late Dr. Clark once answered a question from a member of the audience: how many reedy ridges, does an in situ component have to go beyond the dermal one to separate nodular from superficial spreading? He said 3. He told me that he regretted this more than anything else he ever said in his life. Clark basically hated rules. It's valuable heuristically as a histopathologic pattern, but in terms of type of melanoma, aside from the fact that it's rapidly growing and all the parts of the lesion are fully lethal and that there's a high tumor volume, it's not probably a separate type of melanoma from other melanomas in intermittently sun-damaged skin. So in review, melanoma in low CSD skin or intermittently sun-damaged skin largely corresponds to superficial spreading and nodular melanoma in Clark's classification. The generic criteria that we teach pathologists for melanoma, which we'll go over in a moment, apply well to this type. The most common mutation is BRAF, and a specific one, V600E, that is mutated in well over half of this form of melanoma. NRAS Q61R is another common mutation, and that becomes increasingly prevalent in middle-aged and older patients. So there's 2 bell curves, BRAF V600E, with a peak probably in 30s, 40s, early 50s, and NRAS Q61R with a peak in 50s, 60s, 70s, and 80s. And there's a variety of mutations beyond those initiating mutations and changes in chromosomal copy number change that distinguish nevi from melanoma. And these gradually accumulate. And when you have enough of them, the melanocyte is turned into a fully malignant cell. So how do these start? These start as intraepidermal lesions, whether you call them in situ melanoma or not. They usually grow to at least 6 millimeters before significant invasion happens, but not always. They have poor lateral circumscription, which results in border irregularities, areas in which single melanocytes outnumber nests. In nevi, melanocytes like to be distributed at the sides and bases of reedy ridges, and in melanoma, they lose that preference, and they start going over the arches that overlie dermal papillae. Junctional nests, instead of being crisply demarcated from their neighbors, become confluent. One can have scatter of cells above the junction or pagetoid scatter. The cells of this form of melanoma often have vacuolated cytoplasm and dusty melanin. The dust, the Latin term for dust is pulvum, and I coined the term pulverocytes for this type of cells some years ago. And in the beginning, they may not have enlarged nuclei. Over time, they do. The dermal component has faulty maturation as the cells migrate away from the epidermis. They maintain their size to a great extent, and they maintain their nested quality to a great extent. Cells with abundant cytoplasm and large nuclei become prevalent in the dermis. One can see mitotic figures, which are especially important if they're in the deep dermis, in the mid or deep reticular dermis, not necessarily in the deep part of the biopsy, but in the deep dermis. Lymphocytes and fibrosis are a reaction to those cells. Confluence of nests in the dermis is important. Nests of different size at the same level of the dermis are an important feature. And if you want to be pretentious, you can use this phrase I invented, stratified anisothecosis, meaning different size nests at the same level of the dermis and pigment deep. A few words about melanoma that arise in nevi. We don't know if this happens 5% of the time or 50% of the time. If a pre-existent nevus is present, one of the most important distinctions has to do with host response. Often there'll be lymphocytes and fibrosis beneath the melanoma, but not beneath the nevus. And that's because lymphocytes are often smarter than pathologists. There can be a difference in elastic fiber pattern between the components. elastic fibers being bulldozed beneath melanoma and interspersed between the cells of a nevus. Ki67 and P16 immunostains are usually, but not always, disappointing. If you see an overwhelmingly high Ki67 proliferation rate, that can help you distinguish between melanoma and pre-existent nevus. PRAME in some cases works beautifully, highlighting the melanoma and not the nevus, but in other cases, it's disappointing. And I'm sure there's going to be some questions at the end about PRAME. So let's look at some non-CSD melanomas in situ. This is a biopsy that was probably done with the top of a sardine can, as all too many are, but we can still salvage a diagnosis because single melanocytes predominate. They have large nuclei, abundant pale vacuolated cytoplasm, and are scattered at all levels of the epidermis. A little bit more difficult a case, more of the cells are in the basal layer, but if you observe their distribution, there are many that are in the basal layer above dermal papillae, going over the arches and not just at the sides and bases of the ridges, and high-level pagetoid scatter here, meaning pagetoid scatter in the upper third of the epidermis. And here, at higher magnification, you can appreciate the degree of pleomorphism, both in the sizes and shapes of cells and in the sizes and shapes of their nuclei. A more nested pattern of melanoma. It's easy to mistake this for junctional nevus. A really important principle, maybe the most important thing I'll say today, is that if you see severe solar elastosis, as is present here, and these are very broad elastic fibers in the dermis, and a proliferation of melanocytes overlying it, the presumption of innocence, it's just a nevus, should shift to a presumption of guilt. Why isn't this melanoma in situ? Keep in mind that junctional nevi can occur in severely sun-damaged skin, but you always have to approach the case as prove to me that this isn't melanoma in situ. In this case, there are discrete junctional nests, but there's also pagetoid scatter of single cells in the epidermis between them. Here's one of the junctional nests, and here's the pagetoid scatter in the areas in between the cells. There's also a lentiginous pattern of melanoma in situ in intermittently sun-exposed skin. The lentiginous pattern has single melanocytes at the sides and bases of reedy ridges like a simple lentigo does. I mentioned before cells above the arches, and in melanoma in situ, melanocytes lose their dependence on this environment, the environment of the sides and bases of the ridges, and start to grow in the basal layer above dermal papillae in this nearly continuous fashion. And that's an important clue to the lentiginous pattern of melanoma in situ. Here's another variant of the nested pattern with confluence of nests. We saw a discrete nest previously. Here, if you go from the upper part of this nest all the way across to over here, you can do that without crossing a single keratinocyte or a single collagen bundle. And that's a clue to the nested pattern of low-CSD melanoma. Invasive. Here's melanoma either in situ or very minimally invasive on the right, and here it is at higher magnification, and invasive melanoma on the left. I mentioned pulverocytes before. This is a beautiful example at the lower right, the very dusty melanin in the vacuolated cells that characterize melanomas that are initiated by BRAF mutations more than any other mutation, sometimes NRAS mutations, but usually not gene fusions like the Spitz tumors have. Here's the invasive part of the melanoma with pulverocytes that don't mature with descent. nevoid melanoma in non-chronically sun-damaged skin, smaller cells. Here in this example, pagetoid scatter of more typical melanoma in situ at the top, but the dermal component has very monomorphous cells, and that's what distinguishes it from conventional invasive melanoma. The nodular form at low magnification here, this asymmetrical nodule of deeply pigmented melanocytes with very large nuclei that if you look at the low power picture here, you can see there's an absence of dispersion with descent. Moving from intermittent to chronically sun-damaged skin. So in Caucasians, the face, scalp, the top of the ears especially, but other areas on the ears as well, the forearms, and to a lesser extent, the shoulders of light-skinned patients are the principal sites where this form of melanoma is found. It's more or less similar to what Clark called the lentigo maligniform of melanoma. Its in situ phase is often more indolent than other forms of melanoma, so you get patches that go up to 4, 5, 6 centimeters without any invasion of the dermis. It almost never arises in a pre-existing nevus, and if you see a nevus in the sections, it's usually a coincidence. The melanoma may have overrun the cells of the nevus, and the differential diagnosis clinically is solar lentigo. Here's a historic example, Goya's painting of the Duchess of Alba with this dark patch on the right temple, probably a patch of lentigo maligna or melanoma in situ in chronically sun-damaged skin. Here's a modern example involving the eyelid and unfortunately probably the conjunctiva as well. Histologically, the dermis tends to be more blue than pink in a properly balanced H&E stain. Poor circumscription, I mentioned, often very broad before invasion occurs. This is why it's extremely important when you're looking at small biopsies, especially from the face, to know what the size of a lesion is. And that should be the standard of practice for dermatologists, to put lesional size or include a clinical image that tells you the size of a lesion. So when you look at a 3 millimeter sample, you know whether that's the whole thing or just part of a 3 centimeter lesion. It begins with single cells in the basal layer that usually have scant cytoplasm and large hyperchromatic nuclei. As the lesion gathers steam in the center, you can see larger cells with more abundant cytoplasm and sometimes vacuolated cytoplasm, a sort of final common pathway with melanoma in intermittently sun-exposed skin. I mentioned pre-existing nevus is rare and usually incidental when it's found. Melanomas in chronically sun-damaged skin have a high mutational burden, so lots and lots of mutations, good response to checkpoint inhibitor blockade therapy. The initiating mutations are often NRAS or NF1, neurofibromatosis 1. And if they're BRAF, they're often odd BRAF mutations, not V600E, but V600D, V600K, and other very idiosyncratic ones. So here's an example. Increased numbers of single melanocytes in the basal layer of the epidermis with shrunken appearing nuclei, a dermis that's more blue than pink, and in this particular case, pretty extensive permeation of the basal layer of epithelial adnexal structures. And here's that feature at higher magnification, and that's why surface treatments work so poorly in this form of melanoma. Here's a more subtle example. Note the deep blue dermis, and when you see that, remember presumption of guilt, not presumption of innocence. And in this case, melanocytes, many of which have a high nuclear cytoplasmic ratio, like those in the center here, in near confluence in the basal layer of the epidermis. Another lesion on sun-damaged skin with invasion of the dermis. So one of the risks for malpractice is interpreting a lesion like this on the central face as a dysplastic nevus. Remember that dysplastic nevi almost never occur on centrofacial skin. You can see them on the scalp, by the hairline on the sideburn area, under the chin. But once you get toward the central face, above the jawline, and below the mid-forehead, and medial to a centimeter or two from the sideburn area, they almost never occur. And you have to start thinking, why isn't this melanoma? And in some examples of melanoma in severely sun-damaged skin, you have elongated ridges rather than the epidermal atrophy we saw in the last couple of cases. Acral melanoma. It's defined by site better than other melanomas. You don't get acral type melanomas on the legs or torso or face. You can get chronically sun-damaged skin melanomas on the dorsal feet, but you don't get acral melanomas on the forearms or face. And that's probably because the melanocytes that migrate to the hands and feet are different than other melanocytes. The purest form of the disease occurs on the volar aspect of the hands and feet, so palms and soles. Some lesions occur on the dorsal aspects, but once you get onto the dorsal hands and dorsal feet, you have a mixture of other types of melanomas as well. Acral melanoma also affects the nail, so almost all melanomas of the nail bed and nail matrix are acral type. There is a roughly equal prevalence across racial groups, so being dark-skinned per se doesn't put you at risk. There is some evidence that trauma to the feet causes acral melanoma. The highest prevalence per unit area is the heel and the ball of the feet, where the most impact occurs. And there's a theory that trauma induces double-stranded DNA breaks. Those are misrepaired and result in the gene amplifications that trigger melanomas. So it may be that some of the perceived increase in melanoma in dark-skinned people is cultural, from going around barefoot in trauma to the bottoms of the foot, rather than something inherent to those racial groups. They almost never arise in nevi, and the important drivers tend to be gene amplifications. So areas of chromosomes where there's not just one or two copies of an oncogene, but up to 10 or 20 in some cases. And there's fewer point mutations in acral melanomas. So genomically, it's very different from melanoma in chronically sun-damaged skin and melanoma in intermittently sun-damaged skin. Dermoscopy is an important tool in diagnosis, and it's underused. In acral melanoma, you see not just pigmentation in the furrows, as you see with nevi, but pigmentation over the fingerprint or dermatoglyphic ridges. And this is an example of an acral melanoma where there's intense pigmentation of the ridges. And you can see that sometimes even without a dermatoscope at the edges of this lesion, there's very prominent ridge pigmentation. And if a good clinician, well-versed in pigmented lesions, looked at that lesion, they would say almost certainly that that's an acral melanoma. Poor circumscription is very common, and you can even have lesions like this one, where it looks like there's an area here and an area here that may not even be connected. But if you look in between, there's subtle pigmentation there. And biopsies from these intervening areas often show a very sparse involvement. In acral melanoma, there's usually a lentiginous pattern, meaning single cells at the sides and bases of the ridges. that are similar to melanomas in chronically sun-damaged skin. The cells often have large hyperchromatic nuclei, scant cytoplasm, and thick dendrites. And the sizes of dendrites are not always apparent in H&E stain sections. And getting an immunostain like melan A that highlights the cytoplasm of cells can really bring out the thick dendrites. And especially if you see thick dendrites high up within the epidermis, that can be very important. There's involvement of the ridges above eccrine ducts. Those are the same ridges that lie beneath the fingerprint ridges, and their technical term for it are the cristae profundi intermedii. If you didn't take Latin, that's quite a mouthful, but just remember, look at the ridges where eccrine ducts enter the epidermis and see if melanocytes are preferentially distributed there or if pigment is preferentially distributed there. In acral melanoma, the pigment in the cornified layer is diffuse. In acral nevi, it's often discrete and in thin columns. And the dermal component of acral melanomas tend to have cells with large round nuclei and coarse chromatin, often with only scant cytoplasm. Here's an acral melanoma in situ, and you can see typical acral skin here with a thick epidermis and a thick compact cornified layer, and cells with large hyperchromatic nuclei and scant cytoplasm in the basal layer of the epidermis and to a lesser extent above it. As you look at these cells at higher magnification, you can appreciate the high nuclear to cytoplasmic ratio and the beginnings here of some thick dendrites. To really see the dendrites, as I mentioned before, get a melan A or Martin-1 stain to highlight them. Mucosal melanomas, very similar to acral melanomas in many respects. The intraepithelial portion is usually lentiginous, cells with hyperchromatic nuclei and long dendrites. And like acral melanomas, there's often a high rate of double-stranded DNA breaks that are misrepaired, resulting in chromosomal amplifications and amplifications of oncogenes. Here's mucosal melanoma that's invasive and neurotropic. In this case, the melanoma cells are inside a nerve and not just around it. A little bit of desmoplasia with part of the invasive component in another area. So those are the sort of common types of melanoma. Here's a brief tour through some of the rare forms. Melanomas arising in blue nevi or that resemble blue nevi. The term malignant blue nevus is, of course, an oxymoron, but melanomas can arise in blue nevi, or they can resemble blue nevi and often have the same initiating genomic mutations as blue nevi do. Melanomas that arise in blue nevus can arise in any type of blue nevus. This includes the so-called dermal melanocytoses like nevus of Ito and nevus of Ota that are large pigmented patches, up to cellular blue nevus. They're often very, very thick and have a high tumor volume at the time that they're first detected, and thus have a particularly unfavorable prognosis. They can present either as change in a pre-existent blue nevus, as recurrence in a blue nevus that was thought to have been excised, or just de novo as a dark brown plaque or nodule. The initiating mutations in blue nevus, the most common one is in GNAQ. The second most common is in protein kinase C and is a gene fusion rather than a mutation. And the third most common is in GNA11. GNA11 GNA11 is a mutation that's most common in blue nevi on the scalp, and it may predispose to melanoma more than GNAQ and protein kinase C, GNAQ mutations and protein kinase C gene fusions occur. Those initiating mutations aren't enough to cause a lesion to become melanoma. But if you add a second mutation, either in BAP1, in SF3B1, or in IF1AX, then you can get a blue nevic melanoma. And this is very similar to uveal melanomas, melanomas that occur in the back of the eye, where there'll be an initiating mutation in uveal melanoma. It's usually in GNAQ, and then a second mutation, usually in BAP1, confers lethality. Here's a blue nevic melanoma in a young person, and these can occur in any age. The histopathologic features, most are dermally based. Most occur in the background of a cellular blue nevus and not a common blue nevus or a dermal melanocytosis. There are large oval melanocytes with variably pigmented cytoplasm, many melanophages, cells with large nuclei and nucleoli, sometimes eosinophilic. So these cells are usually not shy about being large. The great pathologist Loren Ackerman, not Bernie Ackerman, wrote a seminal paper on cellular blue nevus in 1968 and came up with the figure that the mitotic rate is often more than 2 per square millimeter. And this has held the test of time. In children, you can see higher mitotic rates, but in adult patients, usually 2 per square millimeter is enough to really suspect melanoma. Necrosis and lymphocytic infiltrates are important. So those last 4 features are things that are especially important in distinguishing the cells of blue nevic melanoma from those of a cellular blue nevus. Here's a lesion, I believe this was in a 4-year-old, where a melanoma arose in a pre-existent blue nevus. The blue nevus is on the left and is less cellular, and the melanoma is on the right. On the left, we can see the spindle and dendritic sclerotic form of blue nevus with a moderately cellular proliferation of melanocytes that have pretty thin oval nuclei and small nucleoli. This is indistinguishable from any other sclerotic blue nevus that one could encounter. And here, unfortunately, is the melanoma. And you can see sheets of these large cells with large oval nuclei, irregular nuclear membranes, large nucleoli, and mitotic figures. There's one in the upper right there, and another one over here. And genomic testing showed that there were some of the common chromosomal copy number changes seen in blue nevic melanoma. So that's blue nevic melanoma. One of the most confusing topics is Spitz melanoma. And there's 2 terms that have been used in the WHO classification. Don't hate me for these terms. I didn't make them up. One is Spitz melanoma and the other is Spitzoid melanoma. So let's start with Spitzoid. That just means that it looks like the cells of a melanoma look like those of a Spitz nevus by virtue of having abundant cytoplasm and large nuclei like the cells of a Spitz nevus have. Within Spitzoid melanomas, which can have any genomic driver, there is a subset of melanomas that share their genomic driver with the genomic driver seen in Spitz nevi. Most of those genomic drivers are gene fusions. They're fusions involving tyrosine kinase genes, either receptor tyrosine kinase genes or threonine serine tyrosine kinase genes, or some other gene fusions. And there's a few mutations such as HRAS and MAP3K1 that also can initiate Spitz melanomas. So Spitz melanomas are a specific form of spitzoid melanoma. And I've listed some of the most common gene fusions at the bottom: ROS1, ALK, NTRK1, NTRK3, BRAF. BRAF mutations are different from BRAF fusions. BRAF fusions are a driver in Spitz melanoma. BRAF mutations are a driver in melanomas in intermittently sun-damaged skin and MAP3K8. So Spitz melanomas, they don't obey the ABCDE rules. They can occur in patients at any age. They're usually papules or nodules or plaques without very much of a color differential. They can affect all racial groups. There doesn't seem to be a strong relationship to sun exposure, and only a few seem to begin in pre-existent nevi, either conventional nevi or Spitz nevi. And here's an example of a Spitz melanoma in a child. This could be a Spitz nevus, an atypical Spitz tumor, or a Spitz melanoma clinically. There's simply no clinician in the world who could look at this lesion and say which one it is. And pathologically, it may be very difficult to tell the difference between an atypical Spitz tumor and a Spitz melanoma. And sometimes, even with molecular testing, there's a gray zone. But if we just see one of those initiating mutations and fusions and no other mutations or chromosomal copy number changes beyond it, it's usually a Spitz nevus. If there's only a handful of additional hits, it's usually an atypical Spitz tumor. And if there's lots of additional hits, especially mutations in genes like TERT or CDK4 or PTEN, then we're dealing with the Spitz melanoma. So histopathologic features of Spitz melanoma, usually well circumscribed, often taller than broad, mostly nested at the junction. The epidermis is hyperplastic, fewer cheminobodies than in Spitz nevi, large oval fusiform melanocytes. Like the cells of Spitz nevus, the cytoplasm is usually homogeneous and not vacuolated, and usually doesn't have dusty melanin. Prominent clefts between cells, large vesicular nuclei, large nucleoli, little maturation or dispersion with descent, large vertically oriented aggregations, and usually no pre-existent nevus. So here's a Spitz melanoma in a 7-year-old girl on the arm. You can see the epidermis is rather thin. That's in contrast to most Spitz nevi, where the epidermis is irregularly hyperplastic. Here's some of the large expansile nests superficially that are thinning the epidermis, nuclear pleomorphism, and little maturation or dispersion with descent. And in this particular case, complete loss of P16. Complete loss of P16 is often, but not always, due to loss of both copies of CDKN2A, which is the gene that encodes P16. That is not definitional for a Spitz melanoma, but it is present in many Spitz melanomas. And if you have complete loss, that adds to the suspicion and adds to the necessity of doing additional molecular studies. Desmoplastic melanoma. Some melanomas begin as skin-colored or tan plaques without melanoma in situ. They're particularly difficult to recognize clinically, and in the past, historically, they've been difficult for pathologists to recognize. Increasingly, they're becoming less of a problem, and they can be much more extensive than they appear clinically, resulting in very, very large surgical defects that are necessary to get them completely out. Here's an example on the face of an older patient, this rather subtle dyspigmented plaque. Here's an example of a lesion on the scalp and the surgical defect that was needed to clear it. So desmoplastic melanomas have mixed and pure types. The pure types just have desmoplastic melanoma and no conventional melanoma. In the conventional part, they're usually spindle cell melanomas. There are thickened collagen bundles between the lesional cells. Melanocytes can have very rare, large, and often diffusely hyperchromatic nuclei. Variability in the sizes and shapes of fascicles is an important feature, and that's sometimes easier to appreciate in immunostains, and lymphoid nodules are common, but can occur in almost any fibrosing process that impinges on the fat. Here's a melanoma that has an in situ component and has a subjacent desmoplastic one. There are confluent nests of spindled melanocytes at the junction. There's sun-damaged skin underneath, but increased numbers of spindled cells in the sun-damaged skin with blue areas and pink areas. The pink areas are a clue to look for infiltration by spindled cells in which are present right there. Note how the spindled cells are sometimes piled up on one another rather than separated and respectful and socially distancing like the cells of a neurofibroma would be. Here's an almost completely dermal one where the spindled melanocytes vary in nuclear size and intensity of hyperchromasia with one another, and that's a clue to the diagnosis. Here's one with lymphoid nodules at the base and infiltration of nerves, and a lesion at scanning magnification with very prominent lymphoid nodules that's going into subcutaneous septa in a very sneaky fashion. So some words about desmoplastic melanoma. NF1 is the most common mutation present in about half of them. The reason that they look like neurofibromas is they share a mutation in NF1. They often have a gazillion mutations and a very high mutational burden. So if you do next generation sequencing, you can pick up lots of UV mutations and lots of mutations in general, but very few chromosomal copy number changes. And to finish up, de novo melanoma of lymph nodes. Sometimes melanoma will arise in a node. It's thought that these can arise from nevi that are present in nodes. The cells of nevi travel to nodes undoubtedly. About 1 or 2% of node dissections for breast cancer will have a capsular nevus. And those probably give rise to some of the melanomas that we see that simply present with a palpable lymph node with no preceding skin lesion. So that's the grand tour of melanoma in 55 minutes. And I hope we have a couple of minutes for questions. And I'd be really disappointed if there weren't any questions because you covered a lot of ground this morning.
Thank you so much, Dr. LeBoit, for this wonderful talk on so many different aspects of melanoma, including molecular features, clinical presentations, history of melanoma as well, and a lot of pathologic features as well. And there are a few questions that I see on our online platforms on both Facebook and YouTube. Let me read them for you. So one question is, what is your advice to our colleagues like who are not particularly trained in dermatopathology, who are general pathologists, and how do they differentiate melanoma from their close mimics like Spitz, nevers, and others? How do they approach, and if they don't have molecular aids to help them? Any advice for them?
Yeah, so just a few things. The great majority of nevi and the great majority of melanomas can be diagnosed on H&E. And in our laboratory, I would say that, you know, we see this year we'll see over 120,000 skin cases. And of those, less than 1,000, including consultations, will be sequenced. So having a place you can refer cases for sequencing is great, but it's not necessary for a great majority of cases. The sort of basic rules of how to tell a melanoma from a nevus done on H&E still suffice for the majority of cases. For Spitz nevi, I would say that if in your practice you have a completely stereotypic Spitz nevus, well circumscribed, mostly nested at the junction, camino bodies, maturation and dispersion with descent, that's within the sort of ambit of a general pathologist practicing dermatopathology. Once you get to variants of Spitz nevi, or Spitz nevi in sun-damaged skin, or Spitz nevi in middle-aged or older patients, those are cases where a general pathologist should drop back and say, you know, I may be confident that this is a Spitz nevus, but I'm going to be extra careful and get a consultation on it. So that's where I would draw the line for general pathologists who are looking at dermatopathology cases.
Thank you, Dr. LeBoit. Here is a question from our colleague, Eliza. So she wants to know, in what scenario would a diagnosis of severely dysplastic nevus be acceptable in heavily sun-damaged skin?
That's an incredibly difficult question. So I think one of the things that we've seen from molecular testing is that in markedly sun-damaged skin, many of the lesions that were previously interpreted as severely dysplastic nevi have the molecular hallmarks of being melanoma. So that's a situation in which I would be extremely careful. And, you know, a couple of things you can do as sort of mental status exam. Firstly is the lesion on the central face. If it is, it's probably melanoma and not a dysplastic nevus of any sort. Another is using P16 and PRAME together and interpreting immunostains was sort of outside the main focus of this lesion of this lecture. But if you have loss of P16 or you have extensive expression of PRAME, you're probably not looking at a dysplastic nevus in that setting.
Right. No, actually, this is interesting. You were talking about P16, and another colleague of ours, Cynthia, has this related question who says that if you had a P16 negativity in a Spitz lesion, would you proceed to molecular testing?
So that's a great question. It depends in part on what you, I hate to sound like Bill Clinton, but what you mean by negativity. So so the negativity I worry about in Spitz nevi is when there's a zone where there's absolutely no staining, or less than 1% of the cells are staining, or the cells that are staining are these little thin curved spindled cells at the edges of nests. That's negativity for me. I see cases that some pathologists send as consultations where they say that P16 was negative, and then you look at the slide and it's positive in 10% of the cells, and the 10% that are positive are scattered throughout the lesion. I don't worry about that. So if there's a completely negative lesion, and it has all the other features of a Spitz nevus, it could still be a Spitz nevus, and I wouldn't say that you absolutely need molecular testing on lesions like that. But if it makes a wrong move in any kind of direction, like it doesn't mature fully, or there's some big, including some big nests at the bottom, or there's increased mitoses, or it's in an older patient, then I would say the the right thing to do is to move to a next stage of molecular testing. And molecular testing now is kind of on a hit or miss basis. In some situations, it's very easy to obtain. In other situations, it's almost impossible to obtain. My guess is that in 5 years, it's going to be very easy to obtain. There are already machines out there. There's a couple of European companies making these things that are almost like an espresso, where you put a capsule in, someone can press a button. They don't even have to be a lab tech, and a day later you have the sequence of the lesion. So unless something catastrophic happens to human civilization, that's coming relatively soon.
Thank you, Dr. LeBoit. We also have Dr. Casarino on our platform today. Dr. Casarino, would you like to add anything, any comments, or you want to have any questions or comments for Dr. LeBoit, please?
No, I think that was a great talk and some very difficult questions. So I don't envy Dr. LeBoit for having to answer all of those questions. I'm glad it's not me. But yeah, I think molecular these days is pretty much unavoidable. We need to be familiar with it. It needs to be part of the residents and fellows training. And I think that was one of the questions that one of the listeners brought up as well. Like, how do we approach training to melanoma these days? I mean, you have to do everything, right? Including, the original H&E, diagnostics, but also immunochemistry, molecular. So, unfortunately, it's just more and more information that we need to know and we need to keep up with, because the diagnosis for a lot of these, at least the more difficult lesions is more and more based on the molecular findings these days.
Thank you, Dr. Casarino. Dr. LeBoit, there is a question from actually one of your colleague, Dr. Mallory Manny, who is actually at UCSF Veterans Hospital. So she has this question for you. She wants to know how best to distinguish Clark's dysplastic nevi from melanoma or melanoma in situ.
Okay. Great question. I just need to somebody's ask. I told them I would be in a meeting at 10, so I'm just texting them going to say I'm late. So Clark's dysplastic nevi from melanoma in situ. That is such a difficult question. It's almost the topic for another hour of discussion. But suffice it to say that the situation that I've seen where dysplastic nevi quote, dysplastic nevi have recurred and proven to be melanomas. The most common is in sun-damaged skin with a lentiginous pattern with relatively small melanocytes. So if you apply traditional criteria, these would be mildly dysplastic nevi or low-grade dysplastic nevi, but in severely sun-damaged skin. So I would say that that's really, and this is, contrary to what you'll read in most textbooks, that's the number one thing I look out for.
Right. Thank you again, Dr. LeBoit. Here's another question from Rafael on YouTube, who wants to know, how often do you use low-grade dysplastic nevus diagnosis versus Clark's nevus approach? And he wants
Okay.
to
Well,
congratulate you for the outstanding work.
that's really simple, because my diagnosis line reads Clark's parenthesis dysplastic close parenthesis nevus, and then there's a note saying that there's an absence of features that would require re-excision, and that's how I currently sign that out. I've thought about just simply stating low grade for those cases. For the reason that I mentioned about sun-damaged skin, I don't think we really know yet what is truly low grade and what is high grade. And the difference between dysplastic nevi that are initiated by BRAF V600E and by NRAS is important. And there's age differences. The BRAF dysplastic nevi are in younger patients. They can have atypical nuclei, and I believe without being pre-malignant, whereas the NRAS dysplastic nevi in older patients tend to have smaller nuclei, but are more likely, paradoxically, to evolve into melanoma. So the way that we've done risk stratification in dysplastic nevi I think, is going to be revised by some of the newer genomic findings.
One last question before you leave, Dr. LeBoit. I think you have to go for your meeting also. Georgios has this question for you. In combined worrisome lesions, bleeds like nevus, what would be the simplest way to prove innocence?
I'm sorry, this question was in combined
Worrisome lesions,
worrisome lesions,
bleeds like nevus, B as in boy, bleeds like.
bleeds like nevus. Does bleeds like nevus mean if you scratch it, it doesn't bleed, or?
No, Blitz, combined blue and
Oh,
Spitz.
Blitz!
I think it was hard to, yeah.
I was wondering if this was a new assay for malignancy. Okay, so there's a couple of things that come to mind. One is firstly, the old idea of combined nevus was just kind of like, oh, we have these different kinds of nevi that can occur together. What we now know is that a lot of these things we call combined nevi are examples of tumor progression. So one of the most common combinations is common nevus plus deep penetrating nevus. So deep penetrating nevi are, more deeply pigmented, so you'll get a very dark brown or sometimes blue-black papule in the background of a brown lesion. And it represents a second hit. In the case of deep penetrating nevus, it's in the beta-catenin pathway. And that second hit causes increased genomic instability. So it's not melanoma, it's in this intermediate group, or this melanocytoma group, as the WHO terminology has it. And some of the same criteria apply as in other types of melanoma: large expansile nests, mitoses, lymphocytic infiltrates, and necrosis. Those are the main features that I look for in general in those combined lesions.
Do you ever use PRAME and P16 in DPNs or combined nevi with DPN?
Yes.
Yeah, I found PRAME seems to be usually helpful. Of course,
Yes.
not always, but it's usually negative in DPN. But I've had a few malignant DPNs that were strongly PRAME positive.
Yeah, no, I found that useful also. And it's especially, if there's a difference in P16 or PRAME between the background nevus and the large atypical cells, I think you can't ignore it.
Right.
I think, Professor LeBoit, these are all the questions that I could find. There may be a few more, but maybe they can reach out to you if they want to ask questions. And thank you so much for this excellent talk covering such a broad topic in itself. And you would be glad to know, Dr. LeBoit, that we had over 100 colleagues who joined from different parts of the world. And I could keep track of colleagues who joined from countries far off as Thailand, India, Nigeria, Romania, UK, Greece, Algeria, Cambodia, Turkey, Sudan, Saudi Arabia, etc. And they're all very thankful for sharing your knowledge with all of them. And thanks to our viewers for joining us live from so many different time zones. It's really appreciated. And you can follow Patcast on different social media platforms if you want to stay updated and follow our lectures. And we will continue with our lecture series. And actually, we have a Latin American lecture series that we are continuing. And our third lecture in the series would be next week on September 23rd. Our speaker is Professor Vania Nohe, who will be giving a talk on thyroid tumors that would be actually in in Portuguese. And she is going to cover on different syndrome-associated thyroid tumors. Hopefully, our colleagues will be joining, especially from Latin American countries, as the talk would be in Portuguese. Hope to see you all at that time. And thank you again, Professor LeBoit, for joining us today. And many thanks to Dr. Casarino and Dr. Skapsky for helping us in organizing this. Thank you so much.
It's been a pleasure. Greetings to all colleagues from all over the world. Thank you.